The title of our lecture today in this series for medical students in cardiovascular disease is cardiomyopathy. We will discuss the subject by this heading: etiology, anatomy, physiology, diagnosis, and treatment with a prognosis. Defined as a primary disorder of heart muscle that cause abnormal myocardial performance, and is not the result of disease or dysfunction of the other cardiac structure like ischemic heart disease, coronary heart disease, systemic hypertension, or valvular stenosis or regurgitation. This is that the classifications are defined by expert consensus panel to define the cardiomyopathy. Say it's a heterogeneous group, lead to that the mechanical electrical dysfunction associated with, usually associated but not invariably, with ventricular hypertrophy and dilatation. There is different causes, but frequently are genetic. Lastly, all these cardiomyopathy leading to the cardiovascular death, progressive heart failure. So this cardiomyopathy, it's a common cause of the heart failure. About 5 to 10% of heart failure due to the cardiomyopathy, with exclude, as we say, coronary heart disease, primary valve disease, and severe hypertension. In general, sometimes we classify the ischemic cardiomyopathy and non-ischemic cardiomyopathy. Ischemic cardiomyopathy due to the coronary heart disease. Non-ischemic cardiomyopathy due to the alcohol, puerperal cardiomyopathy, cardiotoxic drugs. WHO classified as primary, secondary. Primary, as we said, is there usually genetic, and the classified into three groups: dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. While the secondary, there's a lot of causes, some of this infection, metabolic, endocrine, neuromuscular disease associated with, and so on. So these four classification, functional classification: dilated, congestive heart failure, usually ventricular enlargement, lead to that the systolic dysfunction. While hypertrophic cardiomyopathy, inappropriate myocardial hypertrophy, either septum, apical, or generalized, and usually diastolic dysfunction, with exclusion other causes like hypertension or the aortic stenosis. Restrictive or infiltrative abnormal filling, and usually diastolic dysfunctions. Lastly is dysarrhythmic right ventricular cardiomyopathy. So it's heart disease resulting from a primary abnormality in myocardium. Most causes are idiopathic, most likely genetic. Types, as we said, dilated, so congestive, usually most common in all age group in adult population. And hypertrophic cardiomyopathy, 1 in 500 prevalence in general population. The least common is the restrictive cardiomyopathy. We can see this is the normal heart, this is a dilated cardiomyopathy, dilatation, sometimes even hypertrophy. The septal hypertrophy, disproportion to that the free wall of left ventricle, and the next is that the restrictive of infiltrative cardiomyopathy. And the cardiomyopathy is an idiopathic abnormality. Again, most frequently is genetic. The ventricle has become enlarged, as we say, it's enlarged ventricle, thickened, and or stiffness. And these three types, as we said, dilated, hypertrophic, and restrictive cardiomyopathy. Look to this normal and how the disproportionate of hypertrophy, the septal, this is the concentric, and this is the apical. This is the most common, septal hypertrophy, while that the other types of is the rare types, and this is the dilated cardiomyopathy, and that this is the restrictive cardiomyopathy. So dilated cardiomyopathy, primarily systolic dysfunction. Hypertrophic cardiomyopathy, primarily diastolic dysfunction, restrictive cardio, primarily diastolic, but often combined with other systolic dysfunction. The incidence is in general, 3 to 10 cases per 100,000. 1% of all pediatric cardiac disease, and during infancy, incidence 10 times higher than older children. Dilated cardiomyopathy is a common form in the children. Death from progressive pump failure in dilated cardiomyopathy. In first year, 25% die. Second year, 35 to 40%. And 5 years, the 40 to 80. So it's a very poor prognosis and progressively. Stabilization in some cases, but complete recovery is rare. I now come to the first class, idiopathic cardiomyopathy. Dilated cardiomyopathy is characterized by varying degree of dilatation of ventricle, most prominently the left side. Left ventricle dilatation and, as we said, systolic dysfunctions. And pathologically see increase the size of the heart and weight of the heart, ventricular dilatation, normal wall thickness, sometimes hypertrophy, heart dysfunction out of proportion of little fibrosis. The cause is a genetic, most frequently genetic, on a genetic basis, are that the sequelae of might be sequelae of the viral myocarditis. In 20 to 50%, in general, about 35% of cases, the disease is recognized as a familial, usually autosomal inheritance in most encountered, and mutation in the several cardiac structural or metabolic genes have been identified. So it is progressive cardiac dilatation, systolic dysfunction. In about 35% of patients have a genetic form primarily. Large variety of acquired dilated cardiomyopathy. As we said in the WHO classification, secondary. Toxicities, sample alcohol, myocarditis, inflammation, pregnancy, what we said peripheral cardiomyopathy, unknown idiopathic dilated cardiomyopathy. This unknown most likely is there to be the genetic. Myocarditis or inflammation, viral in nature, most often, usually common in children. Coxsackie virus A and B, the most common. Other enteroviruses also can cause dilated cardiomyopathy. Progression from the myocarditis to dilated cardiomyopathy in some cases. Alcoholic cardiomyopathy, types of dilated cardiomyopathy. Alcohol toxicity or secondary nutritional disturbance may be the cause. Ethanol metabolite, aldehyde have direct toxic effect on the heart myocardium. However, it's not distinguishing feature from, clinically cannot distinguish from the dilated cardiomyopathy. Toxicity like chemotherapeutic agent, doxorubicin, adriamycin, and cobalt. Pregnancy-associated peripartum cardiomyopathy, late in pregnancy or weeks to the month postpartum. This dilated cardiomyopathy in the peripartum or peripheral cardiomyopathy, poorly understood, could be associated with hypertension, volume overload due to the physiological change in a pregnancy, nutritional deficiencies, or it might be other causes. Genetic influence in dilated cardiomyopathy is the 35% of patients have familial occurrence. Autosomal dominant, predominant, affect cytoskeleton and oxidative phosphorylations, fatty acid, and beta oxidation, etc. Mitochondrial defects also have association with dilated cardiomyopathy. X-linked induced cardiomyopathy in teenager, rapidly progressive, linked to the gene for dystrophin. Disease with the dystrophin mutation, myopathy such as Duchenne and Baker muscle dystrophy present with dilated cardiomyopathy. Clinically, or dilated cardiomyopathy common at 20 to 50 years old. It's a progress slowly, shortness of breath, easy fatigability, poor exertional capacity, maybe rapidly dip down in the decompensation, ejection fraction to 25% or less, 50% die within 2 years, and 25% survive more than 5 years. And the failure of left ventricle cause an increase in the diastole. This is pathophysiology volume, which result in increased left atrial pulmonary venous and pulmonary capillary pressure. Mitral valve regurgitation functional may result from papillary muscle dysfunction or severe dilatation of valve annulus or ring. Pathogenesis, histologically change are variable, but include myofibrillary loss and interstitial fibrosis and T-cell infiltration. This is grossly to see a large heart with hypertrophy, mainly in the left side of the heart, and left atrium enlarged too. And this is the left ventricle, and this is the left atrium. And this is that the histologically we see interstitial fibrosis and the myocyte hypertrophy characterized by increased myocyte size and enlarged in the irregular nuclei. This is grossly see how the heart is become big and huge and dilated. This is a normal heart. This is that the dilated cardiomyopathy, left ventricle dilatations, and the left atrium too. A clinical manifestation, as we said, all age group may be affected. The onset is insidious, but sometimes symptoms of heart failure occur suddenly. Irritability, anorexia, abdominal pain, cough from pulmonary congestion, dyspnea on exertions are common. Infant and young children have respiratory symptoms and failure to thrive. The skin is cold and pale due to the low cardiac output. Arterial pulse is decreased, tachycardia, palpitation is present, jugular venous pressure is increased, hepatomegaly, edema are common. The heart is enlarged, hollow systolic murmur or pansystolic murmur of mitral tricuspid insufficiency may be present. Blood pressure may be low, pulse pressure narrow, a gallobrhythm AC3 is a common. So it is most patients present with heart failure or are found to have the condition during routine investigation. Arrhythmia or thromboembolism, sudden cardiac death may be a manifestation or a complication of this of dilated cardiomyopathy. Echocardiography and cardiac MRI are the most useful investigation. ECG changes are common but non-specific. Genetic testing indicated for if more than one family member is diagnosed with the condition or history of sudden cardiac death with the dilated cardiomyopathy. So heart failure symptoms, about 85%, inguinal chest pain and dilated less common than hypertrophic, about 20%, emboli, systemic or pulmonary, 4%, syncope or pre-syncope, less than 1%, sudden cardiac death, less than 1%. So in diagnosis of dilated cardiomyopathy, clinical signs, symptoms, chest x-ray, CT scan, echo, and ECG, genetic consult in some cases, MRI, cardiac catheterization, sometimes we need biopsy. So this chest x-ray look to that the enlargement of the heart, full of is the cardiomegaly. And echocardiography look to that the how left atrium and left ventricle is the usually dilated, and you'll find ejection fraction 2 and global hypomobilities. And the ECG combination of the atrial enlargement, varying degree of left or right ventricular hypertrophy, but non-specific. This is how to do the biopsy in certain limited cases with the right ventricular biopsy technique. In management, the focus of management is to control heart failure using the strategies described earlier in the lecture of the congestive heart failure. Although some patients remain well for many years, the prognosis is variable and cardiac transplant sometimes indicated. So management limit activity based on functional class, as we said in the heart failure, salt restriction, fluid restriction, initiate medical therapy, ACE inhibitor, IRB, diuretics, beta blockers, and other line of the heart failure treatment discussed in the previous lectures. So patient with dilated cardiomyopathy, moderate or severe heart failure are at risk of arrhythmia and arrhythmic sudden cardiac death. It's a common. That's why it's rigorous to use beta blocker and other ACE inhibitor or antiarrhythmic. Thromboembolism is a risk, but sometimes use anticoagulation if atrial fibrillation present or other risk factor. Some patients may consider for the implantations of the cardiac defibrillator, ICD, if there is the recurrent arrhythmia and symptomatic, especially VT or VF, and CRT, sometimes we use cardiac resynchronization therapy. So consider adding beta blocking agent if the symptoms persist, where if we start ACE inhibitor, IRBs, and anticoagulation if history of thromboembolism, presence of neural thrombus, and intravenous dopamine, dobutamine, this is positive inotropes, or cardiac transplantation. Prognosis, the course of disease is progressively downhill, although some patients may remain stable for years, unlikely to recover. Treatment of heart failure may result temporary remission, but relapse are common, and in times patients become resistant to therapy. Prognosis for survival in general is poor, and this is the implantation of cardiac defibrillator if the patient has symptomatic tachyarrhythmias. And there is other types of the dilated cardiomyopathy. This is the last in our lecture, Tokostobo cardiomyopathy, what's called broken heart syndrome. This is a form of the acute left ventricular dysfunction, characterized by dilatation of left ventricle, especially at the apex. And due to that, usually the mechanism is poorly understood, but may involve noradrenergic coronary vasoconstriction. In acute left ventricular outflow obstruction, it is often associated with acute environmental or stress or crisis or emotional stress, like loss of close person or earthquake and so on. Present usually with chest pain, shortness of breath, sometimes cardiac failure. It occurs more frequently in women. And in terms of both symptoms and ECG, like STEMI, acute ST segment elevation myocardial infarction, but angiography shows that there is no coronary heart disease or minimal. Echocardiography is diagnostic. And we see the left ventricle resemble the Japanese octopus trap, Tokostobo. This is the picture. So the left ventricle apical is dilated and ballooning. This is the octopus, and this is the left ventricle dilatation of the, and also this is Tokostobo cardiomyopathy. See you in the next lecture is the hypertrophic cardiomyopathy and restrictive cardiomyopathy. Thanks you for the participation.